Good evening, good afternoon. I'm Stefan Verheye from Antwerp, Belgium, and I have the pleasure to be facilitating this session on the reducer therapy together with an outstanding faculty. We are joined by Professor Martine Gilard from Brest in France, who will be joining us in the studio, Dr. Romain Didier from Brest, and also Dr. Hill from the Brompton in UK, London. And then we will be joined also by Dr. Gori from Mainz, Germany. So thank you for joining everyone. And I also would like to thank EuroPCR for organizing this year's course. And also like to thank Neovast for putting this symposium together. So the topic of the session is the latest clinical evidence on the reducer and what are the practical aspects for you to start reducer therapy in your center. The objectives, as I mentioned, was have a better understanding of the reducer therapy, what are the latest clinical evidences, what is needed to start reducer at your site, and we will also touch upon the potential avenues of the reducer therapy, for instance, CTO and also microvascular disease. I also would like to remind you that you're very welcome to submit your questions and your concerns to our chat master, and that is Francesco Giannini, who will be joining us from Italy and who is an experienced operator in the reducer therapy. So it's interesting, you know, before we go ahead here, when you look for angina in the PCR course, there's not much to find, although angina is really one of the main symptoms that patients come to see us cardiologists with this complaint. And so hopefully with this specific session, how to address refractory angina, we will be able to set the stage here and address that concern. And so with that in mind, I'd like to start showing the video of a presentation of a patient with a refractory angina where they initially started the reducer therapy in Brest. So if we can have that video on the presentation of a patient with refractory angina.
It's really a pleasure to share with you the case of Mr. A. I have no disclosure to declare. So it is a 60 years old man with risk factors as hypertension and diabetes type 2. The main prior medical history is coronary heart disease, which required multiple intervention and ended with a CABG on LAD and obtuse margilli by 2 EMA. The biological data, as you see, are within normal range. He describes angina grade 2 and 3, and his LV function is preserved. The coronary angiography shows an occluded left main and a short multistenotic right coronary, as you can see on this slide. For the left arteries, the lima and the rima are patent, but the native coronaries have diffuse atheroma, as you can see correctly in this, on this slide. There is a significant anterior and lateral ischemia on the SPECT, and is still described angina pectoris for poor effort despite treatment. We were unable to offer him anything in terms of revascularization, and due to his frequent hospitalizations and the impact on his daily life, we proposed to implant a sinus reducer. So now let's see the cath lab setup. the cath lab setup is quite different as we use in daily practice. So it's why we want to share with you this point. It's a very important point for us. So we have no conflict of interest for this presentation. So the setup, for me, is a key of this one key of the procedure. As the approach is through the jugular vein, it is important to change the location of the equipment in order to facilitate the treatment. We have to position the C-arm on the left side of the chest of the patient and rotate it to 30 LAO angulation. And as you can see, the table in green should be placed perpendicular to the cath lab table, and the operator, you, have to stand at the top end of the cath lab table in order to do the jugular punction under echo. Here it is an example of setup with the screen in front of the operators and the scopy foot pedal with the operators.
I will show you how to perform a punction under echo. We already see how to place the echograph. Here you can see we locate the internal jugular right vein, and we try to do the local anesthesia and then puncture the jugular vein. When you have punctured your jugular vein, you put your wire inside and then you insert a 9 French sheet. So the puncturing under echo is very important in order to, of course, reduce the risk of puncture the carotid as well, and it's really more comfortable for the procedure. As you can see here, we pierce with the saline the catheter. Then another point that we need to prepare before the procedure is the dilution of the contrast. So the balloon for the reducer is quite different as the other stent. So here you really need to do a dilution of your contrast. Is 20% contrast and 80% of saline. Because when you want to deflate the balloon, you need really to have an important dilution, otherwise you can be on trouble. So this point will be discussed later on, but it's already important to prepare that.
Excellent. Well, thank you very much, Martine and Romain, for nicely demonstrating, first of all, the presentation of the case, and then also, of course, the setup of the lab, which is, I think, is very different from what we usually do in our common practice when we treat coronary artery disease. So as I mentioned, we're very fortunate to have like two groups of people now present. On one hand, we have a group that has recently started doing interventions using the reducer in patients with atherosclerotic disease and basically have no option, who have refractory angina. And then on the other hand, I'm very, very grateful for Jonathan Hill to be present and to be sharing his experience, who has been a long-standing user of the reducer for many years and has done lots of cases. So maybe I'll start with Romain and Martine. What is your process basically? How have you started looking at these patients? How do you collect these patients? And what are the criteria that you think reducer is an option here?
So just I can begin, and after I leave Romain answer. But for me, I think it's important to have the possibility to offer to patients when we cannot do anything else. It's patients who have a lot of revascularization, patients who have cabbage, PCI, and so on. And even with this type of revascularization, they are still symptomatic. And it's a very great difficulty for this patient to have a normal life. So for this patient, I think it's a very great opportunity to offer them a solution in order to decrease this symptom. So for me, it is patients who have still ischemia, because it's important. It's not only a symptom. We have to prove that this symptom is related to the ischemia. But if we have this ischemia proof, and if the patients are still symptomatic, I think it's a great possibility for this patient. So, Romain, do you have some more?
So, thank you, Martine. I perfectly agree with you. But just I will add one comment, because about the selection of the patient, I think you have this patient when you saw your patient every day, because you are thinking, for example, I will propose for this patient a CTO, and this CTO failed, for example, and you can do nothing. So you have still an option. So you can think on reducer. But as you know, some patients you cannot do CTO as well, and you try medical therapy, and the patient still have some symptoms. So you will have some patient for sure for that. At the beginning, we will thinking that we don't have this patient, but just I go on my patient that I see every week, and I find 3 or 4 patients just in looking a few minutes. So I think we have this patient for sure.
Before we go into the CTO, and I think Jonathan would be the very well suited person to tackle this issue, because he has lots of experience with CTOs. But how do you approach the patient? This is like a novel therapy. It has not been implanted many times or in France, and this is like a sort of new kid on the block. And so what is the experience that you have when you propose these patients, like there is this new device? And Jonathan, I also would like to have your take on this.
Shall I go first, or Romain, you go first?
Yeah.
No, you can.
Well, I think if we're talking about the discussion with the patients before they come into the lab, it's actually quite an easy discussion, because our experience is that this is a safe procedure. So trying to explain to people how it works is a little more difficult, but it's possible to give a simple explanation for what is really a safe procedure. I think with the cath lab, when we're trying to sort of reorientate the cath labs to start this procedure, I think there has to be a degree of reassurance that all the skill sets for delivering the device are already present within the cath lab environment. So that anaesthetists often are putting in the necklines in cath labs, but that this is a skill that interventional cardiologists perhaps have done during their more junior parts of their training, but perhaps need to refresh themselves with putting in necklines. Then there is the access into the coronary sinus. Again, interventional cardiologists it's not something they do as a routine part of their practice, but we have all of our device doctors, electrophysiologists who are doing this as a routine part of the practice. So as a cath lab, we have all the skills available. It's just getting the interventional cardiologist, I think, trained up to do those things. There's a little bit of reorientation of the positioning of the patient. So I think the cath lab staff have to adapt to that way of working. But actually, as a procedure, I see it as having 3 distinct components: the neck access, the coronary sinus access, and then the reducer deployment. And I think once people are familiar with each of those stages, then the procedure can be a very efficient and as I've said, it is really generally a very safe procedure. So I think it's easy to introduce if it's broken down into those components and the cath lab staff. Romain, you go first.
Yeah.
No, you can.
Well, I think if we're talking about the discussion with the patients before they come into the lab, it's actually quite an easy discussion, because our experience is that this is a safe procedure. So trying to explain to people how it works is a little more difficult, but it's possible to give a simple explanation for what is really a safe procedure. I think with the cath lab, when we're trying to sort of reorientate the cath labs to start this procedure, I think there has to be a degree of reassurance that all the skill sets for delivering the device are already present within the cath lab environment. So that anaesthetists often are putting in the necklines in cath labs, but that this is a skill that interventional cardiologists perhaps have done during their more junior parts of their training, but perhaps need to refresh themselves with putting in necklines. Then there is the access into the coronary sinus. Again, interventional cardiologists it's not something they do as a routine part of their practice, but we have all of our device doctors, electrophysiologists who are doing this as a routine part of the practice. So as a cath lab, we have all the skills available. It's just getting the interventional cardiologists, I think, trained up to do those things. There's a little bit of reorientation of the positioning of the patient. So I think the cath lab staff have to adapt to that way of working. But actually, as a procedure, I see it as having three distinct components: the neck access, the coronary sinus access, and then the reducer deployment. And I think once people are familiar with each of those stages, then the procedure can be a very efficient and as I've said, it is really generally a very safe procedure. So I think it's easy to introduce if it's broken down into those components and the cath lab staff are aware of just the nuances of the setup, how you position the patient, how you position the table, and who stands where and who does what. So we're standing in much more of a anesthetic position than we are as an interventional cardiologist position.
And it's really a steep learning curve. I think, sticking the jugular vein is maybe not something that we're used to do, but like we have just seen in a demonstration by Martine and Romain, it's really easy when you use or apply echo guidance to study the jugular vein, and it's something that we used to do a lot in the past, but now because of the anesthesiologist, we're not skilled anymore to do this. But with the use of the echo, it's a lot easier to do that.
And of course, every cath lab has, we're all doing our femoral punctures under ultrasound guidance. We're now seeing it increasingly used even for radial puncture. So I think we're all facile now with how the ultrasound, how the echo machine works. And I think it's relatively simple just to introduce it for jugular.
Yes. So for starters, there really should not be a reason not to do it from the jugular because it's so easy to do.
It is, yeah. I think you probably will remember when we were taught by Shmulik Banai is that we weren't using ultrasound. It was positioning the thumb between the two heads of sternomastoid, pointing down, and it was all done in a few seconds normally when Shmulik was doing it.
Yeah, exactly. And to the extreme, actually, you could also do a subclavian approach,
right?
Which I have done in the past as well. If you're not lucky finding the jugular vein, but that's another story, of course. Yeah. Now, in terms of referral, is that something that you have seen problems that you think, like I said at the beginning, angina is something that, we all talk about devices, but sometimes we forget about the symptoms that the patient has. And it's not really patient-centric any longer because we're all so much focused on devices and very sophisticated techniques. But I think we should not forget that angina is really something that is important. And so my question to all of you is, how do you get the referral? So, you can look at it from your internal clinic, but at some point in time, the pool is empty. So you need to find these other patients. And so my question is, what are the options here?
If I may start, our experience was that the referral channel, the referral pathway, was through actually the traditional heart team meeting. So where the heart team, the MDT meeting is essentially the forum where the revascularization cases are being discussed. And by extension, the cases which have had attempted revascularization, for example, the CTO revasc, or in cases where there is no mechanical option, a surgical or PCI option, those types of patients they're all presented in the same forum. And so I think that should be the center of the referral sources. And then there's a process of education for perhaps the non-surgical centers that they need to be aware that this therapy is, so there's a process of education for perhaps the non-surgical center heart team meetings to know that this therapy is available. The second route, which I think is perhaps more appropriate on a regional basis, is to have a dedicated specialist angina or refractory angina clinic and an associated MDT. And certainly that's the approach that's been taken at the Brompton and Harefield hospitals run by Ranald de Silva. And that's really become another very important source of referrals, often from a much broader area than the local referral network. But I would initially concentrate on the traditional heart team and the revascularization MDT meetings that we all take part in.
Yes. Martine, Romain, what is your experience in France? I mean, you just started basically, and you already have done a tremendous job in collecting patients and treating patients with the reducer. How do you advertise, so to say, this kind of therapy in your region?
So I leave Romain after, but for me, it's patients who are in our consultation, patients who are referred by other physicians because they cannot reduce the angina. So they send to us in order to perform a CTO or to explore if there's not a possible type of revascularization of this patient. So it was, we have patients like that with refractory angina without no other possibility who have sent to us, and they hope that we can give us a new solution. So for now, for the beginning of our experience, it's patients who are referred for us from the other physician, from a cardiologist and in the town or in the region, who send us patients because the patients are very symptomatic. They hope that we find a solution, and it was in this patient. Romain, wow, younger, what is your feeling?
Yeah, I think it's the same, but I think another point is also to discuss and to show this device, because most of the general cardiologists don't know about this device. So we need to talk with the other cardiologists as well, but this device is existing and we can use it. It's possible. It's not. It's safe for the patient. So this is a new option. So we need to talk about this new option because most of the people don't know about that. So this is for me the first point, and the other point is the contact. So we need to discuss very quickly with your general cardiologist as well. You can call me and say, okay, I have a patient. He got 10 PCIs. They say it's medical therapy. He's still some chest pain. He cannot do regular things. So he called me and we can discuss this type of device.
Okay, well, having said this is a very important message, Romain, that you just mentioned. It's a safe procedure. Also, let's not forget that it is in the ESC guidelines. So in terms of scientific proof, there is enough evidence. And so now that we're talking, touching the subject of safety and clinical results and outcome, I would suggest that we perhaps switch to the video and talk about the latest clinical evidence of the reducer so far. So if we can have that video, please. So before we go into the talks on CTO and microvascular disease, I wanted to share with you the latest clinical evidence on the reducer therapy. And just as a reminder, before we share the results, I wanted to share with you the study design and the enrollment as where we are today with the Reducer 1 study. The Reducer 1 is a multi-center international 3-arm prospective and also retrospective observational study. And the plan is to enroll 400 subjects. As of March 22nd of this year, we have enrolled 294 patients, of which we can show the results here. The primary endpoints of the study is the reduction in CCS grade at 6 months as compared to baseline, and also looking at the rate of occurrence of device and procedure-related peri-procedural SAEs. Also the MACE, of course, through 30 days post-implant. I mentioned the retrospective arm, that's both arm 2 and arm 3, of which the enrollment has been completed, as you can see on this slide. And the arm 1 is the most important arm, which is looking at the prospective enrollment of the study. As you may recall from the COSIRA data, where we did see a significant decrease in CCS class grade 1 or more and grade 2 or more, which was the primary endpoint of the COSIRA study, we do see at 6 months in the Reducer 1 a very similar reduction in both CCS grade 1 or more and CCS grade 2 or more class. So in the range of about 70% for CCS grade 1 and range 23% of CCS class grade 2 or more. Now, the key message of this particular slide is the fact that the results are sustainable and that about the same degree of reduction has been obtained out to five years, very similar to what we see at 6 months. Obviously, the numbers are smaller as we are still following patients, but the degree of reduction is very similar. Now, when we look at in terms of percentage of patients with angina class 3 or 4 over time, this particular slide shows you that about 70% of patients with class 3 or 4 were at baseline. And when you look at down the road at 3 years, this number has decreased from 70% to 13%. So a significant reduction in those patients who still have angina class 3 to 4. That means that about nearly 90% of the patients are in class 1 or 2. And that is true for arm 1 and also the overall population. What about safety data? Well, you can see on this particular slide that in terms of cardiac death and major stroke, in terms of procedure-related and device-related events, there's 0 patients who have had a major stroke or cardiac death. There's 1 patient who had a myocardial infarction, which was device-related. But overall, when you're looking at these numbers, in 283 patients, the safety data is extremely valuable, and there's only 1 patient who had an MI, which was device-related. Another important observation, which is important for the quality of life and for the symptoms that leads to emergency department visits, this particular slide shows you the number of documented emergency department visits due to angina in the 12 months prior to the Reducer compared to the 12 months after the Reducer. And the bottom line is that subjects with at least 1 visit in the last 12 months went down from 39% to 13%, which means that in the sum of the emergency department visits across all subjects went down from 142 to 31. So the average number of ED visits in the previous 12 months, including subjects with 0 visits, went from 0.89 to 0.19, which in terms of statistical significance is of course very important, reaching a p-value of 0.0001. And then when you look at decrease in the number of emergency department visits for subjects with at least 1 visit at baseline, that means that leads to a reduction of 92% for these patients. So the key messages of the latest clinical evidence on the Reducer 1 study is that the Reducer has indeed a positive clinical effect on patients with refractory angina, which has been shown before, and which is again demonstrated here in this particular analysis. There is a reduction in emergency department visits by 92%, showing also that the Reducer provides a safe treatment option for these patients with refractory angina. And for the first time also, out of 5 years, we can show that these effects are maintained long-term. So I think that we now can switch to the discussion. Thank you. So this almost sounds like a conclusion, I would say. We all agree that this is a very safe device and safe procedure with good outcomes, initially at 6 months. But I think what also is important that we have also shown now for the first time that these results are durable up to 5 years outcome, which is really important. And what is also important, again, as we addressed at the very beginning in terms of angina and comfortness, is that the patient, when you look at the SAQ scores, that these numbers go up, illustrating that the patients do feel better and the quality of life becomes significantly better. And so the question now that we have is, we have looked at all patients with diffuse disease, small vessels, end stage, and then of course we enter the area, I'd say, of the CTOs. And Jonathan, again, as you are the expert of CTOs, I'd like to open the floor and have a discussion on CTO. I know you will be talking about the CTO and your experience. But what is, how do you see the use of the reducer versus CTO? I can imagine for an interventional cardiologist who's very keen on opening a vessel and spend hours and spend lots of money also, versus a simple procedure that at the end, as was also demonstrated by a nice paper by Francesco, is the cost effectiveness of the reducer, done in a multi-center study. So I'd like to hear from you what your thoughts and your ideas are here in CTO.
I think that CTO treatment now has really come on such a long way in the last decade. There really is a spectacular increase in the general success rate, the average success rate. And I think the techniques are much more widely adopted. All the techniques of antegrade dissection re-entry, retrograde dissection re-entry, people's comfort levels with doing retrogrades have dramatically increased. And as a consequence, the general success of the interventional community is much higher. But what that's shown us is that there are these patients that need treatment, and we have to make a judgment about the risk benefit of each procedure. And we certainly have learned that there are certain CTOs that are more difficult than others, perhaps ones which require, say, a use of an epicardial collateral. There are ones which have previously been failed and are actually difficult to complete. So people have been thinking often CTO has been the last sort of option for these patients. But now the CTO operators, who I think are familiarizing themselves with the reducer data, actually see this as a further option for these patients who they previously thought had only one option. And once that acceptance that there may be another treatment available, then people have been saying, well, actually, perhaps it's better to do it before we do the CTO or in combination with the CTO. I don't think we know the answer to that at the moment. I think we're in the process of exploring the various combinations of CTO treatment and reducer therapy. So before or after, as we'll discuss. But I think it's all about the risk benefit and the safety of the procedure. And that's why I think we're having this conversation. There's a much broader conversation taking place about PCI generally, and CTO PCI in particular has, come under a lot of scrutiny. I mean, we're living in the age of orbiter. So, some of us are even questioning whether we should be doing angioplasty at all. So,
and so how would you like to see, if you were to think of a trial, Jonathan, say, reducer, CTO, is that something that is, I could imagine that the trial design would be very complex here, but still.
No, what I think we mustn't do is ignore the progress that's been made in PCI intervention and particularly in CTO PCI. So I think that trial almost needs to be put into the hands of the CTO PCI operators to say, look, we accept that you can do these new treatments. We accept that we can treat pretty much anything now, and say, so there isn't the question of that I think would be asked if you put it into the hands of a device doctor who can access the coronary sinus, somebody who can't deal with all the complexity of the revascularization. So I would like to see it deployed as a tool for the CTO PCI or complex PCI operators as an adjunct to their treatment, or perhaps as a prelude to their treatment, and I think to test those different sequences. So reducer first, then CTO first, then reducer, or perhaps in combination.
Very interesting.
That's what I think we should do. But I would put it in the hands of the CTO complex PCI operators for this particular trial.
Okay, that's very, very exciting. Still lots of work to do. So we are very much looking forward to your presentation. And I think that Martine will then introduce also Dr. Gori on another very exciting topic of microvascular dysfunction. So if we can have Dr. Hill's presentation, please.
Hello, I'm Jonathan Hill from the Royal Brompton Hospital in London. I'm going to be speaking about reducer therapy in CTO patients, what, why, and when. There are a number of combinations about how CTO PCI may be combined with reducer treatment. It's possible to deliver both treatments, opening up the CTO, and then in a belt and braces approach, implant a reducer device. More commonly, however, is that patients undergo CTO treatment, and if there are residual symptoms, then they could be considered for reducer implantation. However, a much lower risk approach would be to use a reducer first and then only treat the CTO if there are residual symptoms. Or we could contemplate just using reducer therapy alone and avoiding CTO PCI and all its attendant risks altogether. So why should we be thinking about reducer treatment in CTO? Well, even in high volume operators and people who have experience at dealing with these most complex patients, the failure rate is around 10 to 15%. And in these patients, there is a significant residual level of ischemia and associated symptoms. Many of these symptoms are refractory to medical therapy. Now, many patients with CTOs also have small distal vessels, which are not amenable to epicardial coronary artery treatment. Now, in this schemata from Stefan Verheye, he takes us through his thinking about patients with refractory angina who may have chronic total occlusion with evidence of ischemia and viability, and that treatment with CTO PCI and coronary sinus reducer need to be contemplated together, assessing both the risks of each of these procedures as well as the benefits. So what are the factors favoring CSR treatment and the factors favoring CTO PCI? Well, as an example, small areas of ischemia favoring CSR, large areas of ischemia favoring CTO. A very highly complex CTO PCI with all its attendant risks would favor a reducer approach first. However, if it's a low-risk CTO PCI, then this may be a very effective way with a low-risk procedure of reducing the symptoms. So in essence, you have to assess the risk-benefit balance. Reducer first or CTO PCI first? So when should reducer be used in CTO? Well, following CTO failure, prior to high-risk CTO, e.g. last remaining vessel or an epicardial collateral, when CTO treatment has a low chance of success. But I think we should also be taking into account the patient's preference. And if you have the option for a low-risk, short procedure over a high-risk, prolonged procedure, I know which most patients would choose. So those are my thoughts on the use of reducer therapy in patients with CTO. Thank you.
Dear Dr. Gilard, thank you very much for this question. Actually, this is something that I really believe in, and this is something that I'm trying to address now in a study. So let me show you just a couple of slides. This is my conflicts of interest, and this is the background why I do believe that the sinus reducer might work for patients with microvascular angina. So if you see this slide, the coronary tree is regulated by different mechanisms dependently on the size of the vessels. If you scroll down, the capillaries are the most important section for the resistances, for the vascular resistances, and they're actually not controlled by biochemical mediators, but rather passively by pressure. So if you want to change the vascular resistances at this level, the best way is to reduce the gradient of pressure across the capillaries by, for instance, increasing the pressure in the venous system with the reducer. So are there data supporting this concept? Yes, even though they are preliminary. This is a study by the group of Giannini, who obviously contributed a lot to this field. And this is only 7 patients, but it clearly showed that CCS class angina, Seattle Angina Questionnaire, myocardial perfusion indexes at MRT do increase and improve after implantation of a sinus reducer, even if the patient did not have epicardial coronary obstructions. Now, this is data from a small study. This is just one patient, but it's quite illustrative of this concept. This was a patient who had even at MRT evidence of microvascular occlusion, and this is the IMR before sinus reducer implantation, as you see, 26, and the other one is the IMR after sinus reducer implantation, 15. So almost a 50% decrease. I do believe that there is a promise there. Thank you very much.
All right. Well, I think that was a very nice introduction, and we all believe that microvascular disease is something that is very prevalent, and there is lots of efforts being done now in order to diagnose with all kinds of sophisticated techniques, IMR, FFR, CFR. What we haven't heard from Tommaso is the fact that he basically, along with also Dr. Da Silva, with Jonathan in London, they are starting a trial on microvascular disease. And there's going to be a trial starting in the Mayo Clinic by Amir Lerman, also looking at patients with microvascular disease. So no obstructive coronary artery disease. And the interesting trial by Tommaso Gori is the fact that they are launching and actually have enrolled the first patients in the, not the COSIRA, but the COSIMA trial, which will be a trial looking at, I believe, over 100 patients, and this will be a double blind randomized trial. So it will be very interesting to see the outcome of these patients and potentially offer a solution for these patients where today there is no solution, basically. Time is running short, and I think in the interest of time, we should now go to the implantation of the reducer, which was a very elegant demonstration that we will see by Professor Gilard and Dr. Didier, who have done their case in breast. So if you can have the implantation video, and then we are left with a few minutes of discussion.
Thanks, Stefan. We will show you, Martine and myself, how to implant a reducer step by step. So the first step will be to position the multipurpose catheter in the right atrium, thanks to a 3 meter 0.35 regular wire that you usually use in your cath lab. So here you can see on the video, the multipurpose is going in the right atrium here, and we try to catheterize the coronary sinus. On the EKG, on the right part of the screen, you can see when you go in the right ventricle, you can have some extrasystole, ventricular extrasystole. And when you are going in the coronary sinus, you don't have this extrasystole. So it's an important point to share with you. Then you are okay, you can advance slowly your multipurpose and catheterize your coronary sinus. So this is the first step is done.
So after we have to make a coronary sinus angiography in order to have a good definition of this coronary angiography, the size, where are the left branch, and when all of them. So as you can see, we connect to the injector in order to have a great sinus coronary angiography, as you can see here, and we decided to implant the sinus reducer here. So we open the reducer kit, and in order to prepare the system. So here it is the sinus reducer. I will show you on the screen here. It's very rigid. It's not so. It's different from our device, what we usually use. Now here it is the 9 French guiding with the hemostasis valve. As you can see, we prepare it, and then we will pull back. Here it is. You can see the guiding. We flush with the hemostasis valve. And then we will pull back the multipurpose catheter on the 0.35 wire that you can see here is going here. So we pull back gently in order to leave the wire inside the sinus. It takes some time in order you have to be very sure that you are in the good place and not traumatic for the sinus. We take out the multipurpose. Okay, so now we have the wire, the 0.35 wire in the sinus, and now it is a very important point, element of the procedure. You have to bend your guiding catheter of 9 French in order to respect the anatomy. I show you it on a compress. It's very important, this part. Okay.
So now, Martine, it's time to do a particular technique. It's a mother and child technique. We call like this because we all know this technique. So we use a multipurpose as a child, and we put in the guiding. So the guiding is the mother here, and we took all these two things on the guide wire, and we advance slowly with these two things. So you see the multipurpose and the guiding as a mother and child here, and this multipurpose will help you to push the guide in the coronary sinus, because the coronary sinus is difficult to catheterize with the guide wire. That's why we bend before, and that's why we use the multipurpose as a support to really, as you can see, very slowly, in order to control the advancement of the guiding slowly and slowly. And when you are comfortable with that, you can retrieve your multipurpose and you are in place with your guiding.
So now, when your guiding is in place, you have to insert the reducer, and here it is. We are, and you can see this reducer arriving on the guiding, in the guiding, and we will place the reducer in the sinus in the guiding. So the guiding is very high in the sinus, and the reducer system are still in place in the guiding, like you can see here.
So now, Martine, it's time to retrieve your guiding catheter, retracting your guiding catheter. So you keep the reducer in place and you remove the guiding catheter. So it's a very important point as well. I would like just to mention that the reducer is between the first and the second marker. And the third marker is just a marker to pull out your guiding catheter. So very important. So you know where exactly is your reducer, as you can see, between the first and the second, and you find the best place to implant your reducer. So usually we go for 4 atmosphere with the pressure, but if we need a little bit more, we can do that.
So
it's time
to inflate. It's time to inflate. As you can see, we inflate the reducer. And this is important. You control the diameter of the both ends of the standby inflation pressure according to the size of the sinus. And you can see here, the proximal part of the sinus is smaller than the balloon and the reducer. So you are in the good place. You're in good. It's correct.
So now we want to pulling back the balloon. So it's very an important plant. As you can see, we deflate multiple times with the inflator, but also with a small syringe to really deflate. We go for 10 times or even more if needed. So this point is really a critical point, because if you don't deflate enough, you can retrieve the stent with the guiding or the balloon as well. So be careful with this critical point. So as you can see here, we deflate again multiple times. And then when you want to retrieve the reducer, the balloon of the reducer, we will advance the guiding. This is the first step. We will advance the guiding at the narrow of the reducer here, but don't cross the reducer. We go slowly, as you can see here. We will advance the guiding through the narrow here. You see? You will retrieve the balloon slowly a little bit, and then you start to retrieve the balloon. You will deflate again because the contrast will be trapped at the end of the balloon because you retrieve your balloon, and you continue to deflate slowly. Of course, you control all this step under fluoroscopy, and if you have any movement of the reducer, stop and deflate again. As you can see, we do very slowly. You can see some contrast at the end of the guiding as well, still trapped. So we continue to deflate. As you can see on the video on the top of the right, we continue. So take time, really take time to do that. We continue. And then we will go slowly again to deflate. It's really to prevent the migration of the reducer. Here, we continue to slightly retrieve the balloon, and we control the advancement of the guiding as well in order to don't cross the reducer. I say it again because it's critical. And now the balloon is in the guiding, so you can slightly retrieve your guiding at the proximal part of the reducer. Slowly. And then we are done with the pulling back of the balloon.
So now we need to control, because it's the end of the procedure, we need to control the placement of the reducer. It is also important. So to do that, we perform 2 coronary sinus angiography. One, as you can see here, through the guiding catheter at the proximal part of the reducer. So you see that the proximal part of the sinus is smaller than the reducer, so it's good. And then we go with the multipurpose catheter through the reducer in order to perform another angiography from the distal part of the sinus, coronary sinus, in order to check it more again. So you see here the implants multipurpose catheter. We retrieve the wire and we perform a very nice and more important coronary angiography, sinus angiography. And we saw that the coronary, the reducer of the coronary sinus is in a very well position. And then this is also very important. It's you remove altogether in order to that the wire will not be trapped into the sinus reducer, in order to don't move the sinus reducer at the end of this procedure. So I think it's very important to respect all the steps.
So Martine, we have done the procedure step by step, but could you please give us some follow-up of this patient as well?
So the news of our first patients, I think that the team and the patients was very satisfied by the procedure. It was not painful and short under local anesthesia, and the discharge was done on 1 day after the procedure. So it's very, very short hospitalization. And as you can see, we performed 3 patients on December 2020, and all our patients have seen a dramatic improvement of their symptom after 1 month. It's not, this improvement does not occur just after some day after. It takes some time to have an improvement, and generally it's around 1 month. And all these patients was very, very have a very important improvement of their symptom. And here I want to summarize what they say to us. The wife of one patient said, "My husband is living again." Another patient said, "I feel transformed." Another one said, I can now lead a normal life." It's very, very important for a physician to have this kind of sentence when they saw their patient. So here it is. We perform a CT because it was the first time we perform this procedure. We want to know what exactly happened after 3 months. And as you can see, for this patient, the sinus is still patent. There is no thrombosis inside, and you can see that the size of the reducer is more important than the sinus, but not too much. And this is enough in order to improve the clinical symptom of all these patients. So for me, it's a real improvement. It's a real good system for this kind of refractory angina, and without possibility of make a new revascularization.
Much, Martine and Romain, for showing and sharing this wonderful case. Great demonstration. Seems indeed very easy. And I just would like to remind the attendees that they will be able to view the case later on in relay, and so go step by step. But as you can appreciate, it's really a very simple procedure. We have time for like 1 minute discussion. I just wanted to know from Martine, what kind of advice would you give a colleague who wants to start the procedure? Very short answer, Martine.
Yes, so I think what is important is to respect the step, because it seems very easy, but if you don't respect the step, there is some problem. As a balloon, as Romain explained, it's not a balloon like the other, so it's difficult sometimes to retrieve it. But I think we have to leave.
And what about DABT? What is the schedule of anticoagulation, antiplatelet therapy? Jonathan, you want to address that?
Yes, I don't think there are particular requirements for DAPT. We've been routinely giving 3 months, but it's, I think, slightly shorter than was in the Casiris study. I mean, I love this, seeing a new centre starting up, because the patients really tell the story at the end. It's wonderful to hear that these first 3 patients have all had a dramatic symptom response.
So in conclusion, it's about the top of the hour. I think we can say that the reducer is a valid solution for patients suffering from refractory angina. I think we've seen that the results are sustainable and long-standing out to 5 years. There's certainly new data coming with microvascular dysfunction, microvascular disease, and we're very keen and looking forward to the outcome of the trials that have been announced. And I think above all, it is a very safe procedure. Thousands of implants have been done so far. With that, I would like to end. I would like to thank the outstanding faculty, Martine, Romain, Jonathan, and Tommaso, who unfortunately was not able to join. And I would like to thank all the attendees, and I'm looking forward to the next session next year. Thank you so much for joining.
Thank you.
Thanks, Stefan.